Welcome to TGS, Transform, Grow, Succeed. And this YouTube channel is all about your work as a caring professional and the ideas that we can share to elevate and expand what we can do to ensure that all of those that we serve get the best of what we have to offer. My name is Dr. Tim Gravois. My pronouns are he, him, his, and I'm the Executive Director of TGS Educational Consulting. And I'm excited to introduce Jacob Meyer, Clinical Outreach Manager for Charlie Health for Southern Arizona, and Art Estrada, the Regional Director for Outreach for Charlie Health for Arizona and Nevada. I invited them on the show today to talk about mental health and especially how we can work better to support the mental health of all youth in our schools and especially LGBTQIA plus youth. And so I guess just as we get started, Art and Jacob, I'm wondering if you just tell me a bit about yourselves and maybe about Charlie Health.
Sure. I'll get started. So my name is Art Estrada. I am regional director here for Charlie Health. I've been with the organization for now 2+ years. And really, Charlie Health found me as they were kind of launching their new market. I've worked in healthcare and in this arena for 20 plus. I mean, I've been in Tucson for 20+ years, and my whole career has been dedicated to healthcare. Recently switched to behavioral health and mental health support with Charlie Health. Really, it's looking at the needs in our community, specifically with our adolescents and young adult populations, at how much need has been seen for providing quality mental health support in this space. So excited to be here and talk a little bit more about Charlie Health. I'll let Jacob introduce himself.
Absolutely. Thanks, Art. I'm Jacob Meyer. I'm the new clinical outreach manager covering Tucson and Southern Arizona. I've been with Charlie Health for about 3 months now, coming from the nonprofit world where I was working in board leadership development. I was really enthralled by Charlie Health's program, there being one of the leaders in behavioral healthcare nationwide. Having had a lot of experience with the landscape out here in Tucson and Southern Arizona from the client side myself, when I saw this service and this offering, it really grabbed my attention for a number of reasons. Primarily, Charlie Health is really leaning into the telehealth model, and they're able to build their intensive outpatient therapy program around this modality, enabling them to pull people from different geographies nationwide and make these groups of approximately 6 to 8 people in size that are curated around shared lived experience and mental health background. So what stood out about that for me personally was, through my experience with group therapy as a client, one of the major issues I had experienced, going to a physical site, was that it was limited by the, sort of other people who were seeking out IOP at that moment in that zip code. And what Charlie Health has really done was they have recognized that one of the primary values of group therapy is acknowledging the shared experience that people have around an issue, and a much more granular issue than just generally struggling with mental health. And having that shared lived experience in somebody else that you're having these conversations with. So Charlie Health is able to get very, very specific around these groups, as opposed to having general adolescent or adult groups. They're able to get, middle school age folks who are struggling with their gender identity or sexual orientation, or college age students who have are survivors of sexual trauma, or people who may be struggling, or mothers who may be struggling with postpartum depression, perinatal mood and anxiety disorders. And I saw the potential for real impact here in Southern Arizona. And it's been phenomenal to sort of be on board and help sort of spread the good word about the program around the various partners that we have here in Southern Arizona, where there's this huge gap of resources to care for people who need that intensive level of care. And we're talking 9 hours in groups, 1 hour of individual therapy over the course of 9 to 12 weeks. This is a huge lifeline for people who we can treat. And so it's really just been great to be a part of, being in that landscape of care out here.
And Jacob, I just appreciate you just talking about just the lack of access in general. And Art, I'm wondering, just because you've been here in Tucson for a while too, one of the things that I just know, having been a school leader and the work that I do in behavioral interventions around, is that it is very, very difficult to find a provider for any child or youth at all. And I'm wondering, how do you see your work as addressing that?
Well, that's a great point. I think what we have identified as, and some of our founders identified in this, and the reason why we built our program around adolescents and young adults is that there's just been a lack of resources in this space. There's a lot of support for substance use programming for adults. There's a lot of support for adults, just adult specific programming, but the lack of resources for adolescent specific has been a pretty stark across the country, especially after coming after the pandemic. And I think we all saw how much the pandemic and especially school age youth has had how much that's really struggled with them with their social anxiety and their engagement. Depression and anxiety has really skyrocketed in our youth. So our founders really looked at what we can do to help address these concerns in our communities. And we looked at this in this model specifically for adolescents who are already engaging online with their peers. This is how they engage on a regular basis, and how we can also use the platform of virtual services to really curate programming and curate groups and get people connected together that they may not have access to in their communities. One of the ways, so Charlie, to come to talk a little bit about Charlie Health, it was founded by three founders. Dr. Caroline Finkel and Carter Barnhart, both were actually met in adolescent treatment and a residential treatment center in their youth, and continued a lifelong friendship from there because they connected over the fact that they had a very similar lived experience. They both had experienced sexual trauma, and they both had that experience of needing mental health support, came from very similar backgrounds. Enter Justin Weiss, who had a really good friend named Charlie, who Charlie Health is named after, who lived in a rural community in New York and was really struggling with his mental health and was dabbling in substance use. Unfortunately, he wasn't able to find access to care at the time that he needed it most, and he actually died of an accidental overdose. So Charlie Health is named in his honor to really help support people when they need it most and get access to care. So what we've seen as some of the driving forces around the need for mental health support is immediate access to care, being payer agnostic, and being able to work with any community regardless of the payer and their financial situation, and also creating high quality care with people that they can connect with. And I think what we saw as part of this, as we see as the school age youth mental health crisis, is that lack of connection, right? Kids were in a really pivotal moment in their time, in their youth, they're not connecting or having the lack of connection to each other, to peers, and to their communities that they would normally need during that time. And I think that's what we're able to build here at Charlie Health, is to have that true connection by having such highly curated groups, and providing evidence-based modalities to really support as many kids as we can.
Well, then I wanted to, if you don't mind, I want to kind of just press on that just a little bit, because I agree that that lack of connection really does drive a lot of the mental health issues that I'm seeing in the schools that I work with and the youth that I'm helping schools serve. And so it's really, and so you were talking about Charlie Health has been created to address that lack of connection, and yet we're doing it online. And many people might say that for the level of acuity that you're working with, we're seeing some really like high intensity outpatient services. Wouldn't an in-person model like lead to better connection?
Sometimes that is the case for depending on the client. But what we have been able to do is what Jacob had spoke to a little bit earlier, is that sometimes you're looking at intensive outpatient services, you're looking at the needs of the community that that community-based group or program can offer. With Charlie Health being a national organization and serving this model in a virtual setting, we can actually connect people with each other that they may not have access to there in their community. So our groups are highly curated, but there's also have a lot of diversity. So we offer over 100 different groups that we run across the week, offering different programmings around, LGBTQIA programming, BIPOC services. We have a whole, like our home maternal mental health programs, female sexual trauma. We have a military family engagement program. So what we're able to do is really pull people who may have not have had those people in their community and connect them together. So early on in Charlie Health, we identified, as we started our program, we identified that over 60% of our population identified as LGBTQIA. So from there, we built a curriculum really supported around that lived
I'm
experience.
sorry, I'm going to stop. Can you just say that number again? Like what percent?
60%.
So this is a topic that we talk about a lot, like whether it's the amount of our youth who are who don't have stable housing that are LGBTQIA plus, the amount of youth that are experiencing depression or suicidal ideation that are LGBTQIA plus, that in every kind of need that we serve as schools, that students that are queer students are absolutely represented in that, and very often not seen. And so just thank you for just bringing that up. I appreciate that.
Of course, yeah. And so what we decided is that we saw this population, and it's like, how can we create more lasting connection with this community, right? So we've created specific groups specific to them and specific to their identity, and even gotten real granular where we have groups that are maybe a little bit more general to the general LGBTQIA population. But what we're seeing a lot, especially with our youth now, is a lot of struggle around gender dysphoria and gender identity. So we've created groups specific to clients that are going through transitions or have identified maybe some gender dysphoria within themselves, and being able to connect them in a group together that also has representation from a clinician standpoint of people who are representative of the community has been tremendously helpful to a lot of the kids that we're serving, and making sure that is not only is that front and foremost for the client, but also providing that support for families. So incorporation to our program, we're not just providing individual and group therapy support for our kids, we're also providing family support for our families. A lot of times, a lot of the struggles that our kids that are identified as LGBTQIA, the struggle is not really coming from their own identity or acceptance of who they are as a person. A lot of it's coming from the lack of acceptance that they're not receiving from their community. So we want to be able to make sure to support the families that are maybe just naive to what it means to be LGBTQIA and help wrap our arms around them and support them so that they can better support their child.
So I wanted to, Jacob, if I could just, I would ask you to kind of add on to that just a bit. It actually sounds like you were ready to do that. So I'll just get out of the way and let you do it.
Oh, of course. Yeah, I was just going to kind of circle back to the point, sort of the virtual model being engaging. And I think that what ARC speaks to is that this is really a beautiful example of meeting people where they are, where you see a generation who is used to interacting online. Notice I don't necessarily say engaging, because I think traditionally a lot of the ways that people have engaged online have been designed to silo them and isolate them from other people. Whereas we are taking this medium, telehealth, and we're using it to build groups that are designed specifically to foster connection around like this very specific clinical therapeutic curriculum that we have that enables people to get those Me Too moments and to have that hyper granular relevant experience. That's going to enable them to see that they're not alone, that what they're dealing with isn't unique to them, and that truly, if there are other people who are going through it as well, that they can also find a way out.
So a lot of times, and especially the work that I do in professional development for teachers and for other caring professionals as well, there's a similar bias where the idea that Tim showing up in person to do the training is going to be so much better than a self-paced online version or even something that we do live on Zoom. And it just isn't the case. It just seems that way to extroverts in my view, where it's like, well, how do we know that participants are going to be engaged if we do it via Zoom? We don't know that anyone's engaged if I do it in person, either. And one of the things that it sounds like that I'm hearing from both of you is that the quality of group therapy depends so much on the quality of the group itself, and geography matters a whole lot less than a good match between the group and the provider leading that group. Am I paraphrasing accurately?
That's correct. I mean, granted, of course, the quality and the talent of the group facilitator is always going to be paramount to the success of the group therapy and the types of modalities that are being taught during group therapy. But we have really, I think, created a niche in the market, and how we've been able to really support our communities is that connection piece, is really pulling people together that can relate with each other and the quality of that group, right? So our groups are not only specific to the lived experience of our clients, but also the the age and the maturity level, right? So we will never put a kid that's 11 years old in a group with a kid that's 17. As you know, as educators, there's a large maturity level that changes between when you're 11 years old and you're 17, right? So having our groups really specific to age, really specific to the modalities that we're wanting to teach them, and helping and giving them that shared lived experience aspect of our programming has been really a big testament to how we're curating therapy and services. And typically with families that are having to access this level of care, we're talking with kids that are really struggling with passive suicidal ideation, who maybe have had attempted suicide, who are struggling with really severe social anxiety and isolation. Sometimes that showing up in person at a facility 3 times a week can be a huge strain and barrier for families to really attend and access care. We know families are busy; they all have busy schedules, and this level of intensity of care may be out of reach for some people, depending on where that local IOP could be located.
They can do it if it's just by their interconnection at home, but ask them to drive 20 miles to somewhere at a specific time that may or may not work for them is a huge hurdle.
It's a huge hurdle. So that's the barrier we want to remove, right? I mean, we work with a lot of families that are in rural communities that would not have access to this care if they didn't live in a larger metro area. So that's really the beauty of the work that we do, is that we're able to reach across all geographies, and also all socioeconomics, because here in the state of Arizona and in many states that we serve, we're working not only with commercial insurance clients, but we're also working with clients that have Medicaid insurance.
Mm-hmm. So here, that would be access here in Arizona, where families that wherever your insurance comes from, so long as you got it, that at least that Charlie Health has a model that the answer can be yes.
Yes. Right.
Okay. Well, that is actually a great place for us to take a break, if that's all right, because I think that when we come back, we're going to want to look at that question of access just a bit more, because that's number one, access, just in terms of there not being anyone here in Southern Arizona to provide the help. Even if we had $1 million, there would be just no one to do it. And then number two, none of our students that we serve have millions of dollars by and large. Generally, there's a real high need for something that's going to be affordable somehow, some kind of way to make any of this work. And very often schools could potentially be sort of the way that folks get to know somebody like you all. Just the same way that they get to know a lot of the providers that we do work with already here in Southern Arizona. So when we come back, I want to let's take a look at that issue of access a bit, and I think that'd be a delicious topic for us to take a look at.
Awesome.
My name is Dr. Tim Devoy, and I'm excited to launch our new free self-paced online course that you can take anytime that feels good to you and watch as much of it as feels good to you as well. And it's called PBIS 101, More Than the Basics of Positive Behavior Intervention Support. And it's going to go over the basics of PBIS for sure, but you're going to get even more than that, because we're going to talk about the key features of Tier 1, Tier 2, Tier 3, what the difference is between all of those different tiers, what are some best practices in terms of getting started, and what are some things that you can avoid to be the most successful in helping your students become successful learners and successful human beings. Click on the link. It's absolutely free. I can't wait to hear how well this course serves you. All right, well, welcome back. We were just talking with Jacob and Art, who are both working outreach for Charlie Health, a mental health organization that exists in 34 states, for goodness sakes, but also, just for my listeners here in Southern Arizona, could very well be a resource just to expand what we have to offer. And if not necessarily with Charlie Health, at least a way for us to rethink, how we go about providing these services. And does everything need to be in person? Is in person even better? And perhaps it really isn't. But one of the things that I want to just talk about is just this issue of access. So just, if all of my listeners are school leaders, and one of the things is absolutely true is that we very often, are the first folks that can uncover that a child is having a mental health need, that the families have developed all kinds of strategies at home that sort of work. And then now we're out in the real world and, oh my goodness, there's some mental health needs or stuff that just emerges that surprises everybody. But it often happens at school or is based on something that comes up at school. And then the reality is even if we can work with families to say, yes, we need to address mental health, at least in Southern Arizona, it's like, okay, well, we've got, the 4 or 5 nonprofit providers that we know of that are great. They're doing really great work, but it can take a long time to get through that intake process. And just even if families, the intake is successful, the first appointment is like weeks out. And even if they get that first appointment, now they've got to take time off work in the middle of a Thursday to get their child or youth to to the appointment. There's just, and then, frankly, who pays for all of this? A lot of our families can't afford to buy school lunch, for goodness sakes. And now we need to find a way to provide intensive outpatient mental health services. How do you work with that issue of access?
So I'm going to take this one. Charlie Health is inherently designed to, address a lot of the inefficiencies that exist within the behavioral healthcare system. And so because we are, geographically distributed and virtual, we are able to be very, very efficient with how we're getting people into care. And for that reason, when we are receiving a referral, we're able to get them admitted into our intensive outpatient therapy program within 3 to 5 days, typically. We are seeing, wait times in Southern Arizona, which can, be many multiples of that, and oftentimes. And what that results in is people will be depending on inappropriate sort of resources to make do in the short term, and ultimately results in a more acute crisis down the road where they may be presenting to an emergency room or, worse. What we strive to do is, through the way that we've designed our program, being payer agnostic, working with all commercial and access plans here in the state of Arizona, and additionally offering grant dollars to help reduce out-of-pocket costs for folks who may have commercial plans with a high deductible. Our mission is to make sure that people have access to quality mental health care when they need it, before it's too late, before they're depending on an inappropriate resource that's going to result in a worse outcome for them. And inherently, what we are able to do in order to achieve these aims is be creative about how we're building these groups. And we're able to be creative about where we're pulling our facilitators from geographically. We have a phenomenal compliance team who make sure that they're licensed to practice in whichever state that the groups are physically, or the participants in the group are physically located in. But essentially what we're doing is that we are taking this tool and we are using it, for our mission to provide access to this quality of care and ultimately to make suicide a thing of the past.
So I'm going to ask you just a real direct question, because let's say somebody calls and a family wants support for their child or for their youth. I would be shocked if the answer could be yes, and by the way, it's going to be less than 3 or 4 weeks. What in general, what does the timetable look like between first call to just to care starting?
Sure. Yeah, that's a great question. So typically, so what we've been able to do is, it's part of our mission is to make sure that we're having immediate availability, access to care.
Mm-hmm.
So one of the things that we've done is have all our groups be rolling. So any client can actually enroll and get admitted into a group, even as it's in session. So there's not any stop or start dates to our groups. That actually helps in one or two ways. It helps us, helps clients that are more veteran in the program really support those that are newer. And also it allows for us to continuously admit clients into care that are really needing it the most when they need it. So as we continue to grow in our outreach, we continue to scale our clinical team to be able to meet the demand of our communities. And we're real strategic and real forward thinking when it comes to that. But typically when a client, let's say a family calls in and says, my daughter needs care, they're asked some specific questions about the behaviors and the symptoms that are being seen. We then schedule what we call an intake assessment or a biopsychosocial assessment with our families. Usually that can be scheduled in as little as 24 hours or as long as 3 to 5 days out. Just depending on the availability of our team and also the availability of the family. That's a 90-minute assessment that's really interviewing and getting to know our clients and understanding their needs for programming. From there, we then can curate a program specific to them. So let's say you have a patient.
Wait a second. So I just want to say, so that initial intake could happen as soon as 24 hours, but generally not more than 5 days.
Correct.
Okay. I just think it bears noting, because that's different than in our experience in Southern Arizona in general with behavioral health services.
And with Access clients, immediately, because we are in network with Access, it's covered at 100%, and there is no prior authorization that's required. So once that assessment is completed, we can actually get a client enrolled, even sometimes same day. We've even had a client do an assessment at 10 o'clock in the morning, and they'll start their first group at 5 p.m. that evening. So we can be that quick and that responsive to the needs of our clients. It really just depends on their engagement and their availability to work with us. So that's the service we want to be able to continuously provide for our communities that we're serving.
So a question that I have is, it sounds really great from an access perspective that people can go from a need to support very, very quickly, because that matters a lot when when we're working with children and youth. And if I'm not mistaken, is I believe that as you range kind of like a 12 to 24 is roughly the age range that Charlie Health serves.
11 to 34.
11 to 34. 11, thank you. So 11 to 34. Let's make sure I get that right. So 11 to 34, which is basically half of the age of the students in our K-12 system right here. So it's an awful, it's a huge need that that could potentially be met right here, and then potentially really, really quick. And then you've got these really great groups. You've got all sorts of good stuff. How do you know that any of this works?
Well, we take sort of our role as being on kind of the bleeding edge of proving the efficacy of this this model very, very seriously. So we are actually partnered with Florida State University, Yale, and Penn, who are doing peer-reviewed assessments on our outcomes data. And the way that we track outcomes are both, we do quantitative measurements, qualitative measurements, we assess patient experience, and then we also look at their utilization of our program. So with that quantitative metric, we're assessing a few different behavioral healthcare indicators. So we use the PHQ-9 assessment, the GAD-7 assessment, and the WHO-5, as well as assessing the frequency of injury or substance abuse. As far as
so my listeners have no idea what those assessments are, but could you tell us just a little bit about like what some of those things, like what are in general, if somebody's doing well on these assessments, what might you be seeing?
So essentially, these assessments broadly are indicators, or sorry, are assessing indicators of sort of the level of acuity of your mental health care or your mental health condition. So like,
how bad are things? And if the assessments are going good, then stuff is getting less and less bad.
Precisely. Each one's scoring a different kind of specific thing that we're looking at: depression, anxiety, and you know, several other different factors that are all meaningful to assess sort of how somebody is progressing and whether they're sort of decreasing on that level of, you know, that acute crisis or that acute.
If you showed up to this group because of depression or anxiety, is that getting any better?
Certainly.
Essentially is what the assessment's looking at. Okay, well, how's it going?
Absolutely. So, so what we're seeing for people who are completing our program, which we see approximately a 90% compliance rate. So that's people who are enrolling in our program and completing the necessary requirements for our treatment. We're seeing a 49% decrease in depressive symptoms.
So I would stop right there. 90% compliance rate. Any chance you know how that compares with standard like in-person clinical options?
That's a phenomenal question. That
I think most, I mean, client engagement is always really difficult, especially in an in-person setting. So, I mean, typically, I mean, if 60 to 70% is what you normally see for people who are attending and engaging with programming. So we actually are at 90%, which is speaking to a lot of things. It's speaking to the engagement clients are seeing in the groups that they're being, you know, being put in, right? So they like the group facilitators, they like their clinical therapists, they're liking the groups and they're feeling connected with it, which is encouraging them to want to engage. So, and to kind of touch on a little bit of what Jacob was talking about is that we follow our clients in these depression, anxiety, self-harm, and suicidal ideation scores from pre-admission up to 12 months post-discharge. So we're not just taking a snapshot of one metric or one time in care of how they're improving and how these scores are improving. We're looking at how long these scores and this improvement that we're seeing in them is lasting, even post-program. So that's what I think has been really telling about our program, is that we're making a huge reduction in these symptoms for kids that are really struggling with high acuity mental health needs. It's been peer reviewed by the other collegiate entities that we are partnered with.
And I think I really appreciate you bringing just that data to the table and being able to talk about it a bit, because that also matters. Yes, well, often in schools, what will happen is we'll be in a child family team, or we'll be in an IEP meeting, or some big discipline event has happened, and it's clear that there's an underlying mental health reason. We'll have to call on the child. We'll have to go to like a crisis response center here in town. And great, they're in some kind of counseling later, maybe, and there's the quality of the work is the connection between the youth and the counselor is so important, but this is very rarely guaranteed, and it sounds like if your compliance rate is at 90%, youth don't go to counselors they don't like. Like they don't go to counselors that they aren't connected with, or at least they'll play a game until they're done. And also all of us who've been in schools have seen this game get played a bit. But then the other side of it is not only are the symptoms down at the end of the program, they seem to stay down 12 months later.
Absolutely. I got one more statistic for you, which is a really
Mhm.
important, and that really kind of strikes to the core of whether or not this is working, right?
Mhm.
And that's that completing Charlie Health prevents 96.5% of clients from readmitting to higher levels of care post-discharge. So
Mhm.
ultimately, like the people who are completing our program, by and large, are not ending up in the emergency room after completing the program. They're not ending up inpatient for, an untold amount of time or worse. And so ultimately, we provide the difference for the vast majority of the people who are entering and completing our program. And for those who struggle, we have, phenomenal wraparound services team who is helping people find, the appropriate resources that are going to be the difference between, their struggles and the potentially brighter future.
Well, and I appreciate you having that data and having more than just kind of words. Oh, we think it works. It seems to be working. I sat in on a group once that seemed to be great. Like the data actually seems to be tracking the work that you do, and that is definitely something to explore. And I think really challenges this idea that whether it's behavioral health, whether it's mental health, whether it's an educational intervention, whether it's professional learning for teachers, this idea that we have to do it in person at all costs. Is very much prevalent in schools for sure. I want to switch, if I may, to another spicy just assumption that I would love to just hear your thoughts on. Most of the schools that I work with are very used to working with nonprofit providers for healthcare and mental health care as well. So we have like a nonprofit dentist that'll show up and do dentist stuff. We have nonprofit mental health providers and behavioral health providers that will very often partner with schools, very enthusiastically even. And those spaces are just all full. Like they're the access to those, even if we have it, are full. Charlie Health is not a nonprofit. You're a for-profit clinic. You provide services and people pay for those services. A lot of times schools are nervous about working with a group that's not nonprofit. What might you say to address that if you were looking to partner with a school?
So I have a nonprofit background. I was working here locally for a nonprofit, like I said, doing board leadership and development for about 3 years before coming to Charlie Health. I still treasure my volunteer service and lay leadership I do in the nonprofit world here in the community. But one of the big things I learned was that fundamentally the important thing to look at is not whether or not an organization is a nonprofit, because fundamentally it's a somewhat arbitrary tax distinction that many people take advantage of, but whether or not the organization is truly mission driven. And so when Charlie Health reached out to me, that was the first thing I looked for. Are these people earnestly trying to make a difference for their community? And the answer was a resounding yes. These are some of the most compassionate and driven people, that I've ever had the, fortune to interact with. And our community is better off for, having them doing the work that they're doing here, both, locally at a state level and nationally. And fundamentally, they are a part of a process that involves public agencies and nonprofits in the community that is all geared towards the health and well-being of our friends and our neighbors. There are advantages and disadvantages to each type of organization, but one of the things for Charlie Health being a for-profit entity that enables it to be very strong in this space is that it's able to work fast to address what is a growing crisis. We are not limited by, applying through grant cycles or seeking solicitation from funders, or structuring our fee for service in a way that's going to enable us to retain talent that can actually deliver impact for the people that we serve. So for this situation, our organization is uniquely equipped to be able to do this work in the way that we are doing it, and we would not be able to do it in the same way if we were a nonprofit. There are many other nonprofits that we have, phenomenal partnerships and relationships with here in Arizona. They refer to us, we refer to them, and ultimately we are all on the same team of doing what we're good at and knowing what each other is good at to ensure that we are allocating the people who need help to the place where they're going to get the help they need.
Well, thank you. And Art, I'm wondering what might you add to that? How much you connect to
I think
that
one of the things that
conversation?
what I've been able to identify with this with Charlie Health specifically is that in any organization, I've worked in healthcare for my whole career, and this is the first organization that has really made the patient the center of their mission, right? I mean, a lot of organizations are really focused on their bottom line, and we're really focused on how do we make this experience for each of our patients better. Even in the short amount of time that Charlie Health has been in its inception, I've seen the diligent work that we do to make sure that we're updating our clinical curriculum, that we're addressing client concerns, and that we're making this whole program about the client and family experience. I think that's a testament to the not only the talent and the drive and the passion that everyone has, from our CEO down to our receptionist at our office in Manhattan. But it really is about making that patient experience better. And Carter, our CEO, always says she wants to be the engine that helps prevent suicide for this population. So that's where really our focus is really focusing on ending suicide for youth and adolescents in our communities.
So whether it's the online model, or the profit versus nonprofit structure, or the ways you structure groups, or the Charlie Health at least is really decided that we're going to do what we're going to do in the best possible way that we can do it. And there's probably like 42 other interviews that we could probably come from that also would be very instructive to us as schools. That very often we're finding ourselves wanting to be very mission driven, and our missions are just very the tools that we have to achieve that are probably different than what we assume that they've always been. And one of the things I just really appreciate just about our conversation just today is just this idea of in person is not necessarily better, and our youth are telling us that it's not necessarily better. That very often we can do much better work in an online model, and shouldn't we offer youth our best? Is a really interesting thing to think about, and something very similar that I think about in this training space for teachers as well is that very often in person is the most expensive, least efficient way to do something compared to an online way of going about things. And then number two, just this idea of access. Payer agnostic is a term that I've never heard before ever in my life. Just the idea of I don't care who's paying for it, we're just going to get it paid, is in many respects kind of nonprofit-ish, honestly, except that we're not relying on a foundation and the whims of that particular board every single year to make it work, which I'm coming to understand is that's why Charlie Health has to be a for-profit model to make all of this work, which I just think is another kind of just really beautiful assumption to challenge, that being a nonprofit, sure, the assumption is that you're mission driven, and most nonprofits are, but there's no reason why it can't be in a for-profit model as well, and still provide the same level of access, if not better, which I think is an interesting thing to kind of think about. So kind of coming down to a bottom line thing, it'll ask us before we take our final break. So let's say I am in charge of connecting students with services at schools, and there's a family need that's emerging, and I want to connect with a provider like you. What would you want them to do?
So I would want them to reach out to me.
Okay.
So my is 520-272-2300. You can call or text anytime. I'll make sure Tim has my email information available. But fundamentally, what I would want someone to take away from hearing my little spiel here is that if you are interacting with somebody who is struggling and is rising up the acuity scale for their behavioral healthcare needs, and they're beyond your capacity to provide appropriate help for, please reach out to me. Regardless of whether or not Charlie Health ends up being the appropriate option, I want to help you make sure that you have concrete next steps to get that person into the care that they will need, and that will make the difference for them. We are a community partner here at Charlie Health. We work with many dedicated professionals and organizations in the community who are all committed to making sure that people, make the recoveries that will enable them to live happy and fulfilling lives. And so we want to make sure that we are a part of getting people the care that they need, regardless of whether or not it is with us. So I want people to consider me a resource and consider me somebody that you can call when you need help.
So if any of my listeners have done any tier 3 training with me, then now we have a phone number to add to our community map, essentially, of outside resources. We can one more possible partner to consider. And now you've had a chance to meet the person that might be on the other end of that call, which I think is really kind of neat. Art, what like is that? What might you add to that?
So one of the things I love about Charlie Health is that we do love a referral. We love connecting with our schools and hospitals and all the other behavioral health communities, in and around Southern Arizona, to get a direct referral for clients that are needing our care. But the beauty of our program also is that clients and families can self-refer. So I'd love to direct them to www.charliehealth.com. It actually is a really thorough explanation of our program, offers testimonials on clients that have gone through our care, and offers a link for you to self-refer yourself. With that referral, that goes to our centralized admissions team, who are prompted to respond to all requests for referrals or admissions into our program within 2 hours. So again, we're very dedicated to being responsive to our families or people that are needing our care. So we will then reach out, review our program with the family or client that is needing access to care, answer any questions they may have, and get them scheduled for that intake assessment right away.
So basically call and get started and make that connection and make the connection ahead of time. And so it just was really beautiful. Well, thank you. Well, let's take a break. And it's just been absolutely fantastic to talk to you today. And I'm wondering, we'll take a break, and when we come back, just kind of given all the ground that we've covered, what final thought might you have for our listeners? All right, let's take a break. Creating inclusive classrooms for students with ADHD is the perfect short online course to learn how to transform the school experience for students with ADHD and to enhance your ability to support their learning. You'll discover evidence-based strategies to improve the social, emotional, and academic success of students with ADHD, even without formal treatment plans or special accommodations. By the end of this course, you'll have an in-depth understanding of ADHD and its impact on learning, how to advocate effectively for students with ADHD, learn how to provide frequent prompts and positive feedback, some amazing strategies that'll reduce unhelpful behaviors and encourage helpful ones, and respond to symptoms of ADHD in a way that enhances connection, reduces teacher frustration, and boosts student success. It's an amazing course, and I hope to see you there. Well, thank you so much for being here today. And I just thank you so much for sharing your experience with our listeners. We're here with Jacob Meyer and Art Estrada, both working in outreach for Charlie Health in different capacities. Jacob, especially here in focus in Southern Arizona, and Art focus on Arizona and Nevada. And just Charlie Health, just for my listeners that might be out of Nevada and Arizona, it works in 34 states. And would definitely be a great resource to look up, and probably the website would be a great place to know, just to find out is Charlie Health active in your state. So it's been just great to talk to you both today. And I'll just, given all the ground we covered, I'm just wondering if you have a final thought that you might have for us. What might you want a school leader or a director of counseling or even a school superintendent to know about how we can work together to support youth and young adults experiencing just high levels of needs in their mental health? And Jacob, can we start with you?
Absolutely. So, I would just start by saying that, we have witnessed and anecdotally have heard about, and increasingly the data is demonstrating that kids and young adults are struggling right now. And for many of these individuals, the first point of contact may not be the appropriate first point of contact. And for folks who may be listening to this and, may have students or clients, friends, neighbors, whoever it might be, who are struggling and who don't know what to do, I would urge you to reach out and to know that there are resources and that there are people who are committed to making sure that folks have options. Furthermore, if anybody is listening to this and is struggling or know of a loved one who is struggling, I just want to highlight the 988 number that is available for people who are struggling with suicidal thoughts or ideation.
Thank you. And Art, what final thought might you have for our audience?
So I think educators specifically have this unique privilege and also responsibility to see our kids in our youth, in our communities, at their best and at their worst. Unfortunately, sometimes the mental health needs of our kids aren't identified until they're seen in school. So with that comes with the unique burden to how do we adjust that for our kids and for our families that we are serving. So as Charlie Health and as a representative of Charlie Health, one of my things is that I want to highlight and emphasize for educators is that you have support at Charlie Health. We're here to help support and identify and support those families. And all we need from you is just a connection to those families so that we can help support them so that these kids can be better in school, better show up in school, be better in grade with their families, and help to identify and address some of the core issues that are contributing to their mental health, and also with the goal of that we're setting these kids up for success for later on in life. That's our goal.
Well, I'm just so grateful for you. I'm just for just the work that you do at Charlie Health, just the way that you make it so accessible, the way that you make it so responsive and quick to get started with that has the potential to make a really huge difference. And honestly, not even potential. You got the data that shows that it's working really well. And so this is just a really good thing just for my listeners who are general school leaders and caring professionals to know more about. Thanks so much for being here today. Just grateful again for sharing all of our experience. I really hope that you reach out to me or to Jacob or to Art just on your thoughts on our conversation. And so for all of my listeners in Southern Arizona, you can contact Jacob Meyer, and I'll make sure that his contact information is in the show notes for sure. And then for anybody else outside of Southern Arizona, you can find the best person to connect with at www.charliehealth.com, or even just call the main admissions line at 866-491-5196. Just call, let them know that, hey, you've got a family that's experiencing some really intense mental health needs, and then they can help you from there. And I'll just for everybody, until next time, just may all of us have as many opportunities to be as good and generous to ourselves as we are with those that we serve. And thanks so much for listening.
Thanks for having us.